Guys, if you like my channel, please give the thumbs up button and subscribe my channel so that it will motivate me for doing more videos for you guys. Okay, so let's discuss the topic of discussion today. Okay, hyponatremia, the normal sodium concentration is actually 135 to 145 millimoles per liter. Okay, so sodium is the most common extracellular cation. Yesterday we discussed potassium, it is the most common intracellular cation. Sodium is the extracellular cation. So what is sodium is actually the total body sodium is not dependent on your actual serum sodium concentration. That means what I want to mention is actually the serum sodium concentration what we are measuring it is not actually reflecting your total body sodium. That's why actually it is defined as the ratio of total body solutes to that of total body water. So total body solutes means your sodium and potassium. Erkel is the one who proposed this actually formula that your total serum sodium what you are measuring is not reflecting your total body sodium. It is nothing but your ratio between your total body solutes and total body water. Okay, so the difference between these two will give an idea, the ratio will give an idea that your patient is having hyponatremia or not. If the ratio is less, then the patient having true hyponatremia. So next is you have to know the serum sodium concentration less than 135 millimoles per liter is considered to be hyponatremia. We have to know when a patient has approached you with hyponatremia, what will he do? There will be actually 4 steps in identification of hyponatremia. First step, if the patient's suspected hyponatremia came to you, you will be assessing history, physical examination, everything you will be doing. Then first step is you will be measuring the plasma osmolality. Okay, so what osmolality, what will you get actually plasma osmolality? You know normal plasma osmolality is how much? That is 280 to 295 milliosmoles. In hypoosmolar state means how much? Hypoosmolar or hyperosmolar. So hypoosmolar means less than 280 and hypoosmolar is more than 295. Whenever patient you are suspected hyponatremia and your serum sodium concentration, you have done an ABG and you have find out that hyponatremia is there and you have done the osmolarity and it is normal, then you have to suspect it may be due to pseudo hyponatremia. So pseudo hyponatremia is causes in which condition it may cause? Suppose the patient having hyperproteinemia or the patient having hyperlipidemia. It may be due to your increased triglycerides or increased chylomicrons or everything. There will be falsely low levels of sodium because it is measured by your ion trapping method, so it will be cause falsely low levels of your sodium, but your potassium your serum sodium concentration will be low but osmolality will be normal. So in these conditions the treatment is not needed. Actually the adequate treatment of hyperlipidemia, not for sodium correction is not needed, but hyperlipidemia you have to correct it with appropriate medications. With whichever chylomicrons is increased or triglycerides increase, we have to supplement them with antilipidemic drugs. Okay, whereas hyperosmolar, suppose the patient, neurosurgical patient or something getting mannitol, or patient having non-diabetic having hyperglycemia, or the patient having sorbitol or something is going, these are the conditions actually, or radio contrast agents. All these patients actually have increased serum osmolarity with low serum sodium concentration. So whenever you are getting hyperosmolar hyponatremia, then you have to exclude all the causes, whether the patient is getting all these things or the patient is ready contrast agents, anything is given, everything we have to rule out and treat accordingly. Appropriate sugar control and mantled ADS dose reduction or something, then it will stabilize on its own. When you are getting hypoosmolar less than 280, then this is the condition having the true hyponatremia. When the serum sodium concentration is also low and your hypoosmolarity is also low, is then it's true hyponatremia. This is step 1. Step 1 is actually your plasma osmolarity. Next, coming to that step 2. Step 2, what you have to do is actually you have to measure the urine osmolality. So when you are measuring the urine osmolality, you come to know whether the if the urine osmoles is more than 100 millimoles per liter or less than 100 millimoles per liter. When urine osmoles presents more than 100 millimoles per liter, what will you suspect? That means there is reduced water excretion. There will be reduced free water excretion. More solute is getting excreted, reduced free water is excretion. What is implies reduced free water excretion means there will be increased ADH production inside the body. It is indirectly reflecting there is some increased ADH production in the body. When the urine osmolarity is less than 100 means what is depicting? There will be more free water excretion. Okay. So then we have to find out there will be decreased ADH can be decreased in this condition. Okay, or the patients may have primary polydipsia. It's the condition in which the patient will intake of the patient water will be more than 18 liters per day. That is more than the kidney ability to eliminate the water from the body, free water. So the excess water will cause water intoxication in the patient. Primary polydipsia, or the condition will cause decreased ADH, or there may be reset osmosat, malnutrition patient, all the kind of patients having less than 100 millimoles per liter. That means they having more osmolality will be less because of the more free water excretion inside them. Suppose in the urine osmolality is more than 100 millimoles per liter, means there is decreased free water excretion. Hey guys, then if urine osmoles more than 100 millimoles per liter, then we will be proceeding to the step 3. What step 3 we will be doing? You know that is where actually sodium is in extracellular cation. So you have to assess the volume of the extracellular fluid. So extracellular fluid volume assessment is the step 3. Depending upon the extracellular fluid volume assessment, you are classifying this hyponatremia as 3 part. Okay. In condition, it may be either hypovolemic hyponatremia, or it may be euvolemic hyponatremia, or hypervolemic hyponatremia. What is hypovolemic hyponatremia? Hypovolemic hyponatremia, your total body water, as well as we are just reflecting the two concentration, total body sodium and total body water. Total body water will be decreased and total body sodium decrease, but the total body water decrease is more compared to the total body sodium. Whereas in euvolemic, the total body water will be normal, but the total body sodium concentration will decrease. Whereas in hypervolemic hyponatremia, what will happen? Your total body water will increase and your total body sodium will decrease, but the decrease in total body sodium compared to the total body water increases more in the hypervolemic hyponatremic patients. When you are getting this kind of situation, then what we'll have to do is step 4, then go to step 4, because we don't know where is the loss. Extracellular fluid sodium is losing, but whether it is because of the what is the cause. So we have to just do your urinary sodium concentration. How much is that we have to mention. If the urinary sodium concentration is more than 20 millimoles per liter, that is 20 millimoles per liter, or it is less than 20 millimoles per liter. If it is more than 20 millimoles per liter means that means urinary renal causes there. Some renal causes are because of this the excretion of sodium is more, so that the patient is getting hyponatremia. So the more than 20 means which are the conditions? Renal, maybe the patient's having diuretic, you are using diuretic use. Diuretics may be loss of the sodium, or else the patient having some mineralocorticoid deficiency, so that aldosterone production is decreased, so sodium water absorption will be decreased, or the patients usually having other cerebral renal, apart from the renal, cerebral salt wasting syndrome, or the patient having the salt losing nephropathy. These are some of the conditions in which there may be increased sodium fractional excretion resulting in hyponatremia. When you are seeing the same thing, hypolemic patient, you are assessing urinary sodium, and the urinary sodium is less, there may be mostly not from the renal, there may be extra renal losses of sodium is more. So what are the extra renal losses of sodium? Then we have to find out. It may be vomiting, patient having continuous vomiting, diarrhea, or the patient having pancreatitis, there is pancreatitis most, or trauma or something. Okay, these are the extrarenal, some of the causes which may result in more excretion of the sodium, and if the renal loss is less, then you have to suspect this extrarenal cause if anything is present, and then we have to treat accordingly to the opinion with the gastrosurgeon for further evaluation, and then treatment accordingly. Okay, suppose if the patient is having euvolemic, the total body water volume is perfectly normal but the sodium concentration is decreasing, then there may be some causes like SADH, syndrome of inappropriate antidiuretic hormone secretion. What will happen in the condition? The ADH secretion is more inappropriately, so more water absorption will be there. There will be dilutional hyponatremia can result, or the patient having hypothyroid, or the patient having hypoadrenalism, that is Addison's disease. I didn't mention all the causes so that it will be more difficult to remember. I just mentioned the most important causes, which are the conditions can result in euvolemic hyponatremia. But drugs are there, causes produces say ADH, there's different group of drugs used, or the patient who is on vasopressin, like analogs like desmopressin or oxytocin, desmopressin, anti-cancer like anti-cancer drug, and antipsychotic like chlorpropamide. Everything will cause euvolemic hyponatremia. When the patient you are getting hypervolemic hyponatremia, the total body water is increased. So which are the conditions? Mostly then you have to see the sodium concentration, urinary sodium concentration. Anyhow, in this patient the urinary sodium concentration is less than 20 millimoles per liter, urinary sodium concentration. Step 4 you will be seeing. Next you will be seeing the same in hypervolemic state. If the urinary sodium concentration is more than 20 millimoles, then there may be acute or chronic renal failure. Mostly renal failure may resulting in retention of the electrolytes will be there. Okay, so acute or chronic renal failure. Whereas in urinary sodium, we are seeing urinary sodium fraction is less than 20 millimoles per liter. Then we have to suspect the concentration is decreasing less, but the volume is increasing. So there may be failure like CCF, congestive cardiac failure, or the patient having nephrotic syndrome, or the patient having hepatic failure. In all the conditions, there may be decrease urinary concentration and increase total body water, and the patient may be having hyponatremia like symptoms. These are the steps. For first step is what will you mention is plasma osmolality, and second step is actually your urine osmolality, and third step we will be seeing the extracellular fluid volume, and fourth step is actually urinary sodium. So now today we have discussed the how will you assess the hyponatremia patient and what are the different causes and different levels of the hyponatremia we have discussed. But it's a lengthy video, I make it as a 2 video. I will be discussing the further how to proceed and what are the clinical features in the hyponatremia patient and management of hyponatremia patient in the next video. Okay, Thank you guys. If you like the video, just give us a thumbs up button and subscribe my channel. Okay, please subscribe so that I can do more videos for you guys. Okay, thank you guys.